you solved my pain, you solved my problem. No, I didn't.
Yeah.
You still have a problem. You're still going to die. You're just not miserable. Pain is an alarm system, but it is not the problem itself. And I think that's one of the big functional thought differences is that yes, you have pain, and yes, the pain's a problem, but the pain's the alarm system. It itself is not the disease or the problem. There's something underlying and your body's screaming for help.
Yes.
And if you can just figure that out, then you can start to deal with what's underlying, knowing that when you fix the problem, the alarm turns off.
We don't live perfect lives in perfect bubbles, right? And so sometimes we mess up. How do we retrain it before it becomes a bigger and bigger problem, right? No different than your pelvis never being addressed. How does your headache not become a bigger and bigger and bigger problem? How do we address these things? All right, so episode 2 of our podcast. So I'm excited for today's episode because I think it's near and dear to patient base, but it's also near and dear to my heart and why I went into chiropractic in the first place. So today we're going to be discussing back pain. We're going to be discussing what the traditional route is. And obviously that's something that a lot of our patients, and including myself, we've gone through. But why that's exactly, or not exactly, but maybe not the best route for our patients to take. Do you have anything to add to that?
I think most patients end up in a chiropractor's office because of pain.
Yeah.
At some point. Like they might have other reasons down the line, but initially it's because of some kind of pain they want to get rid of. And most people end up in a chiropractor's office after they've been to some other doctor.
Yes.
So they've already gotten some kind of a treatment or something. And so we usually, by the time we see them, they're already discouraged.
Right.
Because they've already had an effort and a failure and maybe a couple efforts, maybe a lot of efforts and a lot of failures, but they have something along that continuum. And I think even for me, I ended up in chiropractic as a chiropractor because I had had efforts and failures.
Yeah.
And I was getting worse. And I was like, the things you're doing are making it worse. And that's not helping me any. And so probably the same with you.
Yeah. And I would say one of the goals for us is, especially with this podcast episode, is to maybe make a little bit less of a failure rate in terms of people kind of going through those mistakes. Because I would say, and you can add to this, most people come in here probably a little bit disillusioned, right? And people probably come in a little bit skeptical because they've had a lot of failures, because they've had a lot of authorities also tell them, things and hope that maybe they kind of latched onto and it didn't work, right? And then failure after failure, now they come into our office because nobody recommends it. Right. And we can talk a little bit about that too. Actually, I'm gonna talk about that right now. One of the big things for me, I wrote a research paper back in chiropractic school that talked about how ill-educated American doctors are in terms of the standards, the international standards for back pain. So this is near and dear because I think most primary care physicians are very ill-equipped to even deal with back pain. And obviously we know that chiropractic is way more than just back pain, but for back pain, we are very equipped to help with that versus primary care physicians. And I have a very good friend, one of my best friends is MD. They get very little training in terms of what the standard is, right? That's why people kind of go down that route. So let's get into that. Let's get into what is that traditional route? I can kind of tell you about my story, but I'm kind of curious. What is that traditional route when people get into back pain? In your experience over the past 2 decades, I feel like it's kind of probably remained very similar in terms of what people's entry point is, what they try first, what they try second, what they try third. What do you see, Doc?
In the years that I've been a chiropractor, it hasn't changed that much from the beginning till now. I would say the typical pattern is that they have back pain, they go to their MD. The MD says, well, we have to do conservative care first. So conservative care is synonymous with physical therapy. So then they go to a physical therapist, and the physical therapist starts putting them through a range of exercises, which I know for myself, when I had my problem, doing exercises made it worse. It was actually doing exercises while trying to get strengthened for football that exposed my problem. Yeah. So I'm like, so exercises made me worse, and now your solution is for me to do exercises. That makes no sense. But I played along. I was like, I'll play along. I'll do it. Yeah. So I did it for 2 weeks, and at the end of 2 weeks, I was noticeably worse. And I was like, what's the next plan? Well, the next plan is we don't have a next plan. So you go back to the MD, and the MD goes, well, if the physical therapy didn't work, then the next course of action is most likely going to be surgery. So they look to see what surgeries are even possible. They come up with some kind of a diagnosis that dictates a surgery. So if you've got lateral canal stenosis, then we can do a surgery. If you've got disc degeneration, we can do a fusion. And so people end up with either the roto-rooter or they get the disc fusion, which could be something very simple. Like when I first started in practice, there were a lot of different ways they did fusions. I saw all kinds of weird stuff on x-rays. I saw everything from what looked like they used chicken wire to just bind it, but they never did anything to the disc, to having people have bone chips stuck in there, but then there was nothing else done. Like I've seen all kinds of weird stuff 20, 25 years ago. Now they're all pretty standard. They all kind of look the same. They usually involve some bolts and screws. Look like somebody went to Home Depot. And so when you see it, it looks like somebody just screwed a couple screws in there, stuck some stuff in the disc, and it's just, they've made it stop moving. And so then after that happens, then the patient often says, well, I still have trouble, because what we find a lot of times is that when we identify where the problem is really coming from, the thing that was surgically repaired or had a procedure done on was actually the wrong segment. So it wasn't linked to the proper nerve. And so then you start doing the proper nerve and you get a different result. So it's really comes down to that part of it. So I think it's, especially where Western medicine or even American healthcare fails, and I'll even put chiropractic in the same boat, is a lot of times what happens is it's improperly diagnosed at the beginning. And then once that happens, it actually doesn't matter what you do. So it sounds like we're picking on the treatments. Most of the time, I don't pick on the treatment as much as I pick on the fact that you're doing it to the wrong segment. And if you're off target, you've missed. And
I love that. I love that. And I would add, a couple additional steps, so when my wife went through it, we went through very similar experiences, right? We went through the primary care doctor and the primary care doctor, or actually multiple primary care doctors. And all they recommended first before physical therapy was pain medication or stronger pain meds, right? Prescription pain meds. And we're like, how is this going to fix the problem? Fortunately, we were able to think through that. Okay, how is this going to fix the problem? And so I would say before they even go to physical therapy, it's very strong prescription meds, narcotics or whatever. And then, after that, they would go to physical therapy, and so we went to many physical therapists, nothing, right? And physical therapy doesn't work before surgery. It's a cortisone shot. And then it's the typical three-step cortisone shot, right? So the first one will last, 3 months, and then the next one will last 3 weeks, and the next one will last 3 days. So it's a 3-round kind of thing. And then they go into surgical recommendations, microdissection, whatever, everything that you kind of mentioned. Absolutely. Like one of the big things is they're diagnosing wrong too. One of the big things that we know now from research is the MRI, the gold standard. That gold standard for MRIs is wrong half the time, right? That most people, what we found is most people walk around with disc herniations and they're totally fine. And it doesn't even correlate to the problem. So you're cutting something that is not even relating to that problem that you're experiencing, that sciatica, that pseudosciatica, whatever that you're experiencing.
I think one of the great stories about that is that they were putting people in MRI units and they were seeing these herniated discs and saying, well, there's the problem. And then somebody got the brilliant idea of taking people with no back pain and putting them in MRI units. And what they discovered was that they had herniated discs. Because if you're laying on your back, gravity is going to take it down. And then somebody else got a brilliant idea. What if we make a standing MRI unit? So you make a standing MRI unit and all of a sudden you see all these herniated discs disappear. So are you really just finding a positional anomaly?
Right.
Probably.
Right. Yeah. And even with the stand-up MRIs, as we know, there's posteriority, that might not be causing that issue that person is experiencing, right? And so there might be multiple, so do we just cut them all up, And so sometimes it's just a little bit, and thankfully the research is kind of catching up that the MRI, just because you see it doesn't mean that that's the problem. Then what do you do, right? And so this is where I have a heart for patients because we went through this. Did you know that I think the research is 90 or 80, at least 80%, but I think it's like 90% of a back pain diagnosis is actually non-specific. And this was in my research paper that I wrote, that most people don't get a specific diagnosis. Non-specific diagnosis means I have no idea why you're having that back pain. And that's the primary like medical diagnosis, right? Non-specific low back pain. Well, that's pretty bad, right? If we don't know why you're having it, then why are we throwing up all these tools and all these things? Then if we don't know, why are we introducing motion if we don't even know that's the problem? Why are we introducing, I mean, pain aside, right? Why are we introducing these therapies if we don't even know what the problem really is? So that's big. And that probably contributes to the low back pain or failed surgery or
failed back surgery syndrome.
Failed back surgery. Yeah.
It's now a code.
That's a code. And that's terrible, right?
Yeah.
And patients get the brunt of this. And unfortunately, that path doesn't even include the international standards, right? Which other countries actually are training on this. Manipulation in there, obviously we know manipulation is different than adjustments and Gonstead, and we have that kind of lingo. But even in terms of manipulation, that is also in the standards, yet it's not something that's actually recommended by medical doctors, right? Because they're just not trained in this. If you ask most medical doctors, they have no idea what that protocol really is. So they just follow this very outdated, and this is well documented in research, is very outdated. That model that I'm sure a lot of our listeners have gone through is very, very outdated. And the bed rest, that's very outdated too, right? That's extremely outdated. We know from neurology and the gait theory that that's extremely outdated, like type of recommendations, yet it's still recommended to this day. In our practice, we get people with that bed rest recommendation, but that's all they know.
Well, because there's a principle behind that, the decompensation, that when the body is not, it adapts to whatever strains are on it. And if the strains on it are nothing, then it readapts to doing nothing.
Yeah.
And so if you put somebody in a bed, like I remember when I broke my wrist when I was 12 and I had a cast on it. And after 8 weeks or whatever, they took the cast off and my hand was physically half the size of the other hand. And it felt weird because I could hardly even pick something up, and I'm right-handed. I could hardly pick something up. And at that point, I had already converted myself over to being left-handed most of the time because they wouldn't let me get out of school. Yeah. So I was learning to write left-handed, do all this stuff left-handed, and I almost kept a preference for left-handed. And they were like, "You need to strengthen that wrist, otherwise you're just going to lose the whole thing." So I got busy with it, and I had to get it back, but it was noticeably different. And it was like, if that happens after 8 weeks, then imagine a nerve being shut down and a muscle not functioning for years.
Yeah.
Like, what does that look like?
Yeah. And I think what contributes to that problem, not to go off on a tangent, is also the prevalence of pain clinics as well, which really is mainly drug clinics, right? Yeah. I know someone who managed that clinic, and it's mainly drugs, and they're unfortunately start getting hooked to those drugs because it doesn't actually help with what research has shown with the gait theory, more movements, and all. It just masks it, right? And so if you keep masking it, and you have to take stronger and stronger because you're just masking the problem, right? And so, yeah, we gotta talk about what that solution is, right? And I think hopefully we can enlighten the listeners as to what we have found that to be. So, anything to add to that?
Well, I was thinking about the whole pain issue. I had an issue once. I had a gallstone get stuck in the common bile duct, and I didn't know it. But out of nowhere, I started having pain 3 to 5 in the morning. I was doing Lamaze breathing every morning, 3 to 5. Yeah. And so then I made this comment to my wife that I saw the hospital out the window, and I was like, I'd rather be over there than over here. And she's like, you never want to go to the hospital, so we should probably go to the hospital. So I went to the hospital, and the doctor quickly figured out what it was. He's like, it's stuck in there, but because you can't get the bile out, now it's backing up into your liver. You're going to die like probably within 48 hours. And I was in tremendous pain. So he gave me morphine. Yeah. And all the pain went away. And so I said to him, being me, I joked with him. I said, you just give me a doggy bag of that stuff and I'll be out of your hair. And he's like, yeah, and then you'll be dead at home. Yeah. So yeah. It's like, but I thought it's just so funny because I could tell. I'm like, I said that to him because I thought, I know he hears this all the time. You solved my pain. You solved my problem. No, I didn't. Yeah. You still have a problem. You're still going to die. You're just not miserable. And so it's like you can there very peacefully die. Yeah. And so pain is an alarm system, but it is not the problem itself. And I think
Yeah.
that's one of the big functional thought differences is that yes, you have pain, and yes, the pain's a problem, but the pain's the alarm system. It itself is not the disease or the problem. There's something underlying and your body's screaming for help.
Yes.
And if you can just figure that out,
Yes.
then you can start to deal with what's underlying, knowing that when you fix the problem, the alarm turns off.
Yeah.
So that's why I don't want to numb you out. I had a patient the other day that I appreciate that. They said, I've thought about taking pain meds and I thought, no, I won't, because I want to know if what
Yes.
you did. And I said, that's what I want to know too, because if it didn't do it, I got to keep hunting. But if it did it, then we know we found it.
Right.
And that's worth a lot. So same
Yeah.
kind of idea, like let the pain be, and we'll see if we get rid of it by solving the problem, not by just masking it, making it go away. And I guess that's the problem I have with pain clinics. When I've had patients who are going to pain clinics, they often do successfully mask their pain. And then it makes it really hard to figure out if you're doing the right thing or the wrong thing or helping them at all. It really
Yes.
makes it confusing.
Yeah, absolutely. And pain is one of those things that is confusing. You know, I mean, it really is. When you start studying the neurology of pain, it is confusing because, you know, you got things like phantom limb syndrome, you know, like
Yeah.
you have things, right? I mean, as much as we say, we basically, you know, we have that age old like thing that we say, the absence of pain doesn't mean that you're healthy, right? We can talk about that in a future episode, but, you know, I would say that pain is actually a gift. It's actually a gift because it's that alarm system. If you didn't know that you had, or if you didn't have that alarm system, how would you have gone to the doctor, right? And so, you know, I mean, it is a gift. It's God's gift that we have an alarm system, that we have something saying, hey, something's wrong, right? Yet what do most people do? They put masking tape over that alarm, right? You got an alarm going off. It's like, hey, that's kind of annoying. I'm just going to put a masking tape over that. And what happens? It just keeps going off. So you just put more and more and more. And maybe your neighbor's alarm is like, hey, put masking tape over that. Is that the solution? No, it's not the solution, right? It's find out where that problem is. Where is that fire starting from, right? And so
if you had a fire in your house and the fireman came over and then all he did was rip down the alarm and leave,
yeah.
you'd be like, what a failure of a fireman.
Yes.
And yet, if you have a doctor that rips down the fire alarm and leaves, you go, oh, yeah, that did it. He was the one.
Yeah.
Really?
Yeah, exactly. Yeah. It's masking the fire alarm, which is the pain meds, right? That analogy. And then it's ripping it out, which is the surgery. Well, you still have that problem. You just got, yeah. And so, you know, and I get it. I totally get it because we were begging for, you know, this stuff. So I get it. If you start in the wrong path and 90% is non-specific diagnosis, right? And a non-specific low back pain diagnosis, then where do you go from there? Patients start trying to take control of their health. They start trying to go through anything, right? We were going through weird Chinese remedies, you know, anything we could do because nothing was giving us that solution. That's why on that first episode I talked about Kat actually hearing about that cause and breaking down and crying, right? Without even, I mean, it's like, I just told you why you have back pain. That's all I did. Yet crying because of that, right? I mean, patients really need to, you know, hear that, right? They need to start with the right place.
The one other side of pain is that there is a point at which pain is so intense and so overwhelming
Yes.
that you feel like I can't even function and you just want to get your functionality
100%.
back. So I get that because, well, yesterday I couldn't walk.
Yeah.
I sneezed, messed up my back, couldn't walk, could hardly move. And I was adjusting people anyway. But as I was going through the motions and moving, especially when I had to move the knee, chest, tail, and bend over, I realized that now my low back doesn't hurt. My mid back hurts. I'm getting a headache. It just starts to take over.
Yeah.
And I thought to myself, man, if somebody didn't know what was happening, I can see why this would be so bothersome to them.
100%.
And yet, because it's me and I know even what my problems are, I was like, ignore all that, focus on this. And then as I got it adjusted and I got ice on it, got the swelling down, got adjusted a couple of times, today I feel like somebody punched me in the butt. But other than that, I'm up walking around, moving, adjusting people. And in one day I went from unable to move to be able to move. So it's not just something we do on other people. It's something we experience. Like when it's bad like that. But I get the idea of the pain is so intense that I hear people say all the time, I just want to be able to think again. I just want my life back. I just want to be able to function.
Yeah.
Like, I get it, but it's all in solving the problem. And when you start getting those extra pains, if I was a patient and didn't know and started telling me, somebody said, what's wrong with you? Well, my head's really hurting me. Because at that moment, my head was really hurting me. but that wasn't the source of it.
Yeah.
I knew it was a low back
Right.
problem. It had just grown into a head problem. So people tend to focus on the latest pain.
Yeah.
And then that actually pulls you away from the original pain, which is probably the real problem. And so even in that process, it's not anything intentional, but patients end up distracting the doctor, and doctors are human. We'll take the lead, and we'll go down that rabbit trail with you. And it's really hard to stay focused on where is it really coming from, and not just go chasing rabbit trails because this is the pain of the day.
Yeah. For sure. Yeah. And so that kind of combines principles, 3 and 4, and, which we'll talk about in a second. One of them is, what is palliative care versus curative, restorative, whatever we want to call it. Right. And healing takes time, right? If I break my arm, I'm going to take medication, right? If my arm is like protruding out of my, and I have an open fracture, I am going to take that, knowing that the medication is not going to heal my body, but I know that in order for me to get the full restoration of my arm, it needs to heal, right? And so it's still all about healing, yet healing does take time. And so so I totally get when patients kind of go through that, and I would do it. I would do the same thing. So
I think that's the missing ingredient, the fact that all healing takes time. And the more healing you need, the more time you need.
Right.
And yet I've never had a problem with, if I know what the problem is, like a broken arm is a good example. I know what the problem is, and we're in the process of healing it. It's okay to take meds. You don't have that's not your permanent solution, the meds. It's getting you through while you get the healing.
Yeah.
But when you're taking meds because you're like, my arm hurts and I don't know why, and it's broken, but you don't know, well, I'm just going to take meds for the rest of my life and keep the pain down.
Right.
Well, that's not solving the problem. So it's like, it's not a this or, it's a, you can do it but meds only make sense once you actually know what the problem is and you're just trying to keep the pain under control while you're making the healing happen.
Right. Yeah. And so those things, we got to really make sure, that the listeners understand that we are not anti-medication. We're not anti-medical profession. That is not what it is. We want to educate people. Obviously, we want MDs to also know this, the actual standards that are in the studies, right? That are in medical literature. So we are not anti, but we want to make sure that there's a time and place for that, right? Because what happens is when you start taking that medication, when you start taking that, and you actually never really solve the issue, there's a phenomenon that's called central sensitization. And so what happens is, your nerves, those sensory nerves, which is basically, how you start feeling, right? The afferent nerves that you start feeling, they start branching out more and more of those nerves, the sensory nerves. And so more branches means more pain for the same exact input, right? And so if you never really I understand why you want to take more and more and more of those drugs, because it does feel worse and worse and worse. Even if the problem stays the same, because there's more input and nothing's being done about that, our body is smart to say, hey, that alarm is going to keep going louder because you got to do something about that. But what does the patient do, right? And if there's no solution, then they're screwed, and that's not a good feeling too. So
I like that. There's a study that shows, that I was looking at not that long ago, that shows that when you have a disc problem, it leads to changes in the brain. And then as the disc gets better, the changes in the brain don't immediately change. So you actually can heal the disc faster than you can heal the brain.
Right.
And so then the longer you've had it, the more changes in the brain, the longer it's going to take to heal the brain part.
Right.
And so then this pain perception can still be coming from that brain change, even though the disc itself is fully functional.
100%.
And that's like, it really messes with people's minds, because they're like, no, I feel it in my disc. You're like, yeah, but it's actually functional. It needs the brain to come back around. And that's actually where movement becomes more of an issue. So now movement is key. It's not key when it's broken. It's key when it's fixed. And now it needs to reestablish that pattern. So like you were saying earlier, it's the right tool for the right job at the right time.
Exactly.
That's the key.
Yeah. Yeah. So let's get into it. Because we keep alluding to it, and we've talked almost about all the principles, but let's talk about just those steps that patients should go on, because I feel like this is not just applicable to low back pain. These principles, it's applicable to anything, right? So when people really understand what should happen and how to kind of have that framework and philosophy around it, they can go from being disillusioned to being really skeptical, from being hopeless, right? To getting to that, knowing that, their best days are ahead of them, right? Not behind them,
Mhm.
right? Where it's like, okay, well, I'm screwed. And you know, back, back a few years ago, I was able to, no, like, let's talk about how you can, actually improve. First principle, we talked about this. I call it a funnel diagnosis, right? And so what a funnel diagnosis to me, what that is getting all that information, right? Understanding what's going on with your orthopedic tests, right? With your neurological tests, with understanding, is it a muscular issue? Is it a disc issue, right? Is it truly a piriformis issue? Is it really stenosis, right? Really understanding what that really is, rather than just doing an MRI, which we already know, we just talked about, is not the gold standard for low back pain diagnosis. So getting all the information, right, and in all the realms, instead of just saying, oh, you need exercise. Well, do you know that it's an exercise problem? Do you know that that's a muscular, right? It's a muscular motor control issue. Are you focusing on the motor control? Are you focusing on the strength? Is it weak? Is it weak? Is it an antagonist that's weak? Like, what are you working on? Or are you just going for something, right? Just to do something. So getting that diagnosis is super crucial, but it comes from a place where you have to kind of know, and it's a funnel, because we got to be able to pinpoint what is that true thing, right? What is that one in the Gonstead world? What is that one segment? In what direction is that bone subluxated, right? If you had to bank it all on that one problem, right? Because we know that it's not five problems, right? It's one problem. I might have cascaded into secondary problems, but there's still a primary problem, what we call a primary subluxation, right? And that subluxation is in a very specific direction that we're going to see on the x-rays, so that we can apply the next step, which is the right tool in the right order. But you can't apply anything unless you figure out what's going on.
I don't know. And it can get a little more complicated in the pelvis, but especially in the spine, it's going to be one, but then the other ones have to adapt to that one. And so that's when you start going, well, how many times have I heard? Well, it started in my low back, but then a couple months ago, I started feeling it more in my mid back. And now I'm starting to get neck pain and headaches. Well, yeah, of course, because the rest of your body has to start adapting. And it's a slow process, but as it adapts, now you got other pressure points that are holding pressure. Basically by pressure, I mean the weight of your body on the disc. And yet it's not physically balanced where it needs to be. And so one of the things, like studies show, inside the disc, the nucleus is in the middle, and your center of gravity needs to be within the boundaries of the nucleus. And as long as it is, it holds you up. Once your center of gravity gets outside the boundary of the nucleus and now starts being bared on the annulus fibrosus on the outside, that's not that's meant to do. All of a sudden, now you have dysfunction, and your body and your brain immediately recognizes it and goes, okay, I've got to shift my upper body to move my center of gravity to get that weight bearing back over that nucleus. And so it's all subluxation compensation, subluxation. It's all the body trying to figure out how to keep you upright so you can keep walking and stay mobile. Even yesterday when I was so messed up, I could still walk. It was ugly and slow and bad, but I never lost the ability to walk. And that's very common. Most people don't. In fact, by the time a patient's lost the ability to walk, they're in really bad shape. Right. Because now they can't compensate anymore. Their body's run out of every option. It's like, I give up. Yeah. So that is a bad sign.
For sure. Yeah. And, even headaches, right? And we'll go into that in a future episode, but headaches being caused by your pelvis, right? And we, as Gonstead doctors, this is why we look at the entire spine, right? The traditional diagnosis with most places, right? With most healthcare practitioners, you're looking at, just a neck problem, or you just have a lumbar spine problem. And they're just going to focus on, imaging, maybe MRIs of just that section. Right. And so that's what happened. I had headaches for a very, very long time. I actually went to a doctor and I got prescribed a lot of medications, really strong medications for it. Right. And then what they did before they did that was an MRI of my head. Right. And then they're like, oh, there's nothing wrong with your head. Well, if it's in your case, are they looking in your pelvis?
Yeah,
right?
I was looking down there, but that's where it is.
Right. Yeah. And so how are you carrying weight? And simple example is if the listeners can see me, right? If I lift up my right side, my pelvis, well, my neck is going to be kinked this way. Well, that kind of strains this part of my neck right now. So if I go harder and harder because I can't walk on that side, we can see how weight bearing has a lot to do with it, right? And so I could start working on your neck and massaging it or even adjust it. But is that really going to help you in the long run if you're walking around with that limp forever? Not really, right? And so getting that funnel diagnosis of what's primary, what's secondary, what's tertiary is really, really important, because that disc problem that you have that in your neck, right? If I was doing this, maybe a tertiary problem. We don't know, right?
Yeah.
It might be a primary problem. In fact, it might actually be the thing that's actually causing your low back pain too, right? We have the above down, inside out type of philosophy too. So we just don't know until we really analyze. And in our work, people always wonder, I think they confuse the tool, the adjustment, with the diagnosis, because they're like, why don't you just adjust me the first visit? Why do you have to spend all this time figuring things out, right? And so why do you have to take a full spine x-ray? Why do you have to do the nervous scope? Why do you have to do all this stuff? Why do you have to look at my case history, right? Why do you have to look at all these things? Well, because we're trying to get all the information and figure out what happened. What's the first thing that happened? Oh, did they fall on their back? Is that why they have a compression fracture there? Well, that's going to affect the stability over. So it's well worth the time to work on it. You're not going to go to a dentist and be like,
just drill.
Just drill. Just go drill. Yeah, you got pain? Let's just drill, right? And that's my tool, right? And if it doesn't work, I'm going to drill somewhere else. That's what most people do with chiropractic, right? They're like, well, just adjust, just start popping things. We're talking about your spine, right? We're talking about an input into your spine. How's that any different, right? And so headaches. So why don't you start
I think
there?
it would blow most people's minds to know that migraine headaches don't come from the neck or from the head necessarily. And so when you have a migraine headache and you go to a practitioner, where are they going to look? They're going to look almost exclusively at the head and the neck. The head MRIs, neck exercises, they stick to the head and the neck, and yet it's a sympathetic problem that comes from further down. And so when you don't have an understanding of the mechanism of what causes it in the first place, you don't understand those things, then you end up in this pain thing of wherever the pain is, that's where the problem must be. It's like the most dangerous thing when you're just thinking that what hurts is the pain, and where the pain is the problem, or where the problem is the pain. And so I still have a pain in my elbow, so I think I need elbow surgery. Like that just takes you in a totally bad place, because that's not usually the case.
And where do migraine headaches typically come from?
They're usually upper thoracic, and the mechanism is that there's actually a sympathetic nerve from the upper part of the back that runs up the back of your neck and into the back of your head. And being sympathetic, it causes vasoconstriction, so it constricts the blood vessels. When it's inactivated and it's limp or dysfunctional, it doesn't create the constriction. So what happens is anything that increases your blood pressure, your pulse, bending over to pick something up, as the blood pressure goes up, there's no vasotension to hold it, so it blows open, and that blown open blood vessel is what gives you the migraine headache. But it's controlled by a nerve that comes from the upper thoracics, and so that's where you have to look, is in that upper part of the back, not the neck.
Right.
It's just a different mechanism than what people think. It's not even close to being the same mechanism as tension headache. It's nothing like that.
I think that's where we totally get, the listeners that are out there, we totally get when people want to take control of their health, right? And it was just like me, right? Just looking straight into my head, yet there was nothing wrong, yet I was still having headaches, right? This is the same thing that people have with the low back. There's nothing wrong. The doctor said there's nothing wrong with my low back. Well, they're looking at maybe one part of it, not the entire picture. But it's well worth the time to find that pinpoint diagnosis, right? Where we can just take into everything into consideration and just keep narrowing it down into what is the first problem, what's the secondary problem, what's the third problem, right? Similar to your headaches that came from yesterday. It was not the primary problem, yet we probably might need to adjust that. So if it's causing you issues, and a secondary problem is, so we totally get where pain comes from, but it's well worth the time to find out what that is, right? And so this is where people ask, why do you need to take why do you need to look at my whole x-ray, right? Why do we need to look at nervous scope? Why do you need to look at basically the neurology of the nerves, right? Why do you need to look at my case history? Why do you need to know what happened before? Just, this is what's happening now. Well, because we need to get to we need all the information to pinpoint what exactly is it? Is that a secondary problem? Do we address the tertiary problem first or the primary problem first? What do we need to do? And that kind of brings us to the right tool in the right order, right? And so one thing that we're really adamant about is doing things. And there's so many things, and this is something that we were discussing before, is there's so many great tools out there, amazing tools, amazing gadgets, things that cost boatloads of money, amazing robotics advances in surgery, and right, the most amazing beds. We were talking about that. But is that really the right tool, right? And how many people do we have coming in here that have spent boatloads of money on the most fancy beds that can recline, go up, down? I don't even know what's out there right now. Yet they're like, but it didn't work. Or I had, what is the gun, whatever, the massage gun, percussor, I don't even know what it's called anymore. But I spend boatloads of money on that, yet it's not the right tool, right? And so the classic example we give is having a disc herniation, yet going to soft tissue or massage. And they're like, man, I've been getting massage. How many times have you heard this? I've been getting massage for the past couple of years, right? And that's helped me. It helps me for like a day or two or a week maybe, but it comes back, right? And it's a great tool, right? There's plenty of great tools like the release and all these things, but is it really the best tool for disc herniation?
Well, in that situation, one of the really weird ones is a patient will come in and say they went and got a massage and now the pain's 2 times worse, 3 times worse. It's not because the massage therapist did anything wrong, and it's not because they're bad. It's because you have an inflamed nerve, and an inflamed nerve hates to be massaged. They don't like to be moved. They don't like to be stretched. They don't like anything. So that's actually, for me, it's very diagnostic, because if somebody thinks that they have it's very common for people to confuse muscle pain with nerve pain, thinking, I pulled a muscle. They stretch the tendon, and so they have a muscle kind of injury, even though if you realize that muscles don't produce pain. Nerves do. There's no such thing as a nociceptive muscle. It doesn't happen. So nerves are communicating. So it's always a nerve issue. Even when the muscle doesn't work, it's still a nerve issue. But let's say you were out running and you pulled a muscle, overstretched the tendon, and you get that hot, melting water kind of feeling coming down your leg. That versus a swollen nerve feels almost identical, except they respond well to the opposite thing.
Right.
So if you put ice on the nerve's happy. You put heat on the muscle's happy. So if you put heat on it thinking it's a muscle and it gets worse, it's actually a nerve. So it becomes diagnostic to figure out which is which. And so it's just realizing that you have a swollen nerve in there. And if a massage therapist goes in and starts massaging it, that's not the right thing. Whereas if you've got a tight muscle from overexertion, if I do a lot of cycling, my legs get sore, and I'll even self-massage. It's not because I don't have a nerve problem. I have an overworked muscle, and I'll massage it. It feels good, and it kind of loosens it up, and I can go riding again. That's very different from a swollen nerve that's inhibiting function, can't walk, can't move, constant pain. It's a different problem. And so it is a matter of figuring out which problem do I actually have, and then doing the right thing for that problem. Whatever it may be.
And honestly, even kind of the semi-right thing, right?
Yeah, just get in the ballpark.
Right. But the most amazing tool for the wrong application is going to do worse than an adequate tool, but applied in the right place, right? And so for your headache, right? Me giving you the best therapy, percussor, Theragun, and whatever massage on your neck. Honestly, when you have a pelvis problem that's causing it, really, how far am I going to get, right? And so an adequate tool, but with the right diagnosis again. So it's really, really, really important for the listeners to understand that having the right pinpoint diagnosis is well worth the time. You wouldn't want a medical doctor to just be like, oh, cool, I have back pain. Here, take 5 of these medications. One of them will work, right? But that's kind of what people expect with chiropractic is, okay, within 5 minutes, why can't you just start smashing on my bones, right? That becomes problematic.
That's a challenging one, because setting aside healing of the disc and things like that, even the nerves themselves, I always tell patients nerves are slow. So if I make a profound adjustment to a nerve that's had a lot of trouble, I expect you might get a benefit by tomorrow, maybe the day after that. And I always tell them that the nervous system has to essentially reboot like a computer. And your reboot is when you sleep. So if you're feeling better before you've even slept, then I know you're going to be a lot better.
Right.
And then you sleep and it does the reboot, and the next day you'll be a lot better. And if it doesn't do it on that first reboot, that just means you had a really severe problem. The computer's having a little trouble. Then I start to compare it more to like an engine on a cold day where it needed to turn over. So you give it a try and it vroom, 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 and it didn't quite turn over. So then tomorrow night you sleep again and vroom, 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 it tries again. And eventually it'll turn over. And when it does, then it kicks into a new mode. And so nerves are slow. So for it to change and be profound in even an hour is a big deal because they don't do that. That's not usually what nerves do. They're much slower than that. And so it's just be patient with nerves.
And sometimes chiropractic might not be the first thing too. So we were talking about that we're not anti-medication. We're not anti-surgery. I've broken my wrist. I have plenty of scars. When it's almost popping out of my skin, I'm not going to go to a chiropractor first, right? And so I'm not going to wait until things heal. I'm going to take some meds.
Yeah.
And
I've sent lots of people for hip replacements when I figured out that their bad hip was the reason they were having pelvic issues.
Right.
And so once the hip goes down and you've got bone on bone, we're not fixing that. So I've sent lots of people for surgeries on that.
Okay. So there are things in the right order. And sometimes for us, it's even ruling out us as the first option too, right? If a disc is so far extruded that we're not going to make a difference, then we are not the first thing. So the right tool in the right order, we may not be the first thing that people go to. It may be a surgeon, right? And
sometimes we're not the first piece of the puzzle, we're the last piece of the puzzle. So a good example of that, I had a patient who he was involved in a head-on collision when a drunk driver crossed a median, hit him head-on. They were on the freeway. He was probably going 70, 80. They were probably going 70, 80 or more. So this was a high-impact collision. When he showed me what he looked like in the hospital on his cell phone, I could take some stuff, and I nearly threw up. I was like, you got to warn people with that. It was nasty what happened to him. But they put Humpty Dumpty back together again. They sewed him all up, and they had him going. And he was still walking with a limp and having a lot of disability. And he was 6 months or more healed up, but he wanted to get back to doing his job. And he had a physical test he had to pass. And he didn't know how to do it because he had this limp. And he walked in the first time with a limp and all this noticeable problems. And as I started evaluating him, I realized I said, there's no way you're breaking bones that you're not misaligning joints too. So they're concerned about the broken bones and the things that aren't attached to things that should be attached to things. Yeah. They're putting all that back together. But once they've done that, you still have an underlying biomechanics problem. But now that you're healed up, I'm not worried about that too much. Let's fix the biomechanics. So we did. He gave me a time limit because he had a physical test to take. So I think we only had like 3 weeks to put this guy back together. So I saw him pretty frequently. And in 3 weeks, at the end of 3 weeks, he took the test and he passed the test. He was able to climb over a fence. He was able to climb on a motorcycle. He was able to do all this stuff. And it actually worked out. But it was interesting to see how it was a biomechanics issue separate from the other injuries. But as I told him, I said, when you first go to the hospital, their goal initially is to keep you alive. Then their goal is, how do we start putting things back together so he could function like a human should function? But what always gets left out at the end is the fact that you can have minor things that are not going to kill you in the next 10 minutes, but they're the biomechanics issues that will start to really bug you over the next 10, 20, 30 years. Mm-hmm. So we fix those things and you get back to normal movement and you don't wear the joints out, and it plays its role in the end. So sometimes we're at the beginning, sometimes we should be at the beginning, sometimes we should be at the end. And so these kinds.
Unfortunately, with how practices primary care, we're not anywhere even in there before surgery. Yeah. So, which we're not going to go into that rant. But I would say this is another thing that it relates to the right tool in the right order. It's that the concept of more is not better, right? And so more is not better, even in terms of more therapies, we try not to combine a boatload of things, adjustments with soft tissue, with whatever, because one, I think there's a couple problems with that, and you can tell me your thoughts, but one of the problems I have with this is, how do you know what worked, right? Mm-hmm. Even if I'm doing a bunch of adjustments, how do I know what worked if you feel better the next time? How do I know how long it's going to last, right? So the tool is almost a differential diagnosis in itself. If it doesn't work, right, or if it only lasts a little bit, that gives me a lot of information, right? And so I don't think more is better. And I know many, many people who come into our practice, they're surprised that we try to be so precise. But instead of, why don't you just crack me left and right, my neck left and right, my back left and right. And so more is not better.
If I took no notes on a patient and that patient came in and said, what you did last time was the most amazing thing, just do that again. I had no idea what worked. It's the same as having too many things and then I don't know what worked.
Right.
Or it also works the other direction. They could come in and be like, that was awful. Don't ever do that again. Well, great. I don't know what I did. So I know my notes are different than some of the other doctors because the things that are important to me are different. And so I keep notes that are a little bit different. But to me, it's like a playbook of here's exactly how you can repeat everything I did. And it's not actually for somebody else to repeat what I did. It's for me to repeat what I did so that I can figure out, well, even if it wasn't right, is there some part of this I can tweak? And so I give myself these weird details about things that I tried this and tried that, and then I know what it means. But it's true. This tiniest little detail can be the difference between it being better, completely better, worse, horrible. And you have to figure out what's that little detail. So there is, unfortunately, a little bit of a trial and error because sometimes we do something and the patient's better and we go, you're better, but not as much better as you should be. I need to figure out what to tweak and what not to tweak to try to go from good, great, a little tiny bit.
Analogy that I use, and just relating to that, is having a sniper rifle versus a shotgun, right? So when you have a sniper rifle, you can try to get the wind right, you can try to get the coordinates right and set the scope and all that, which takes longer, right? It takes us longer to set the scope and figure out what's the wind conditions, what's going on with this patient's history, what's going on with our scope. But do you hit it right 100% of the time? No, right? You don't hit that bullseye every single time and hit your target every single time. You start getting better with practice, but sometimes that helps you determine what your next shot is going to be. And so, unfortunately, how do I say this? It can be very frustrating in practice because of the precision that's required. Precision of not just the diagnosis and how precise you have to be at that bone in that direction, but also the application of did I lift it enough? Did I adjust it in the right vector, right? And so that's part of the frustration, but it's well worth it, right? You're not going to go to a medical doctor and they give you five medications, you feel good about it. One of these is going to work. That shotgun approach, I think people intuitively know with medical, but I don't think they intuitively know with chiropractic. Would you say the same thing?
You don't know what I left myself a note one time that was on a particular patient where something like push in 25%, go around the left-hand corner and then put it on the shelf. It was that kind of a note because I knew what that meant because I'd felt it. But anybody else reading that would be like, what is he talking about? But I just knew what that was. And I knew for that patient, if I didn't do exactly that, they weren't going to get the result they wanted because it was that finite. And yet it's true. Most people going to a chiropractor don't know. In fact, I sometimes wonder if I'm the patient, sometimes I can't tell the detail that they're going into because it's just a different perception feeling it with my neck versus with my own fingers.
Right.
And so I'm like, I think you're doing it right, but I can't tell as much. Whereas with my own hands, I know exactly where I am down to a fraction. So I think as a patient, when you're the one getting adjusted, even if you had developed it, which nobody does, you still wouldn't really know for sure. All you know is to me, it's comfortable or it's not. And there's tricks to making it comfortable. In fact, I just readjusted somebody and the first adjustment was uncomfortable and the second adjustment was comfortable. So we were trying to dissect what was done differently on the second one that I did that would make the first one more comfortable. Where did the first one go wrong? And it's that kind of thing that you have to do that and figure it out. Whereas a patient, you don't know. You only know when it doesn't work or when it's not comfortable, especially when it's not comfortable. I knew that as a patient when I was a student and people would set up on me. I would think to myself, I don't know what they're doing, but I don't do that. There were things that I started to figure out that I didn't want to do because every time it was done to me, I could feel how uncomfortable it was and I could feel myself tighten up. And I don't want my patients fighting me and I don't want to be fighting them when I'm the patient. So that's the part you're trying to get rid of.
Right. It reminds me of the quote, practice doesn't make perfect, perfect practice makes perfect. Right. So
so the challenge is how do you get perfect?
Yeah, exactly. That's the beauty of Gonstead. That's the beauty of specificity, right? If you only had one shot, I feel like I'm Eminem there, but if you only have one shot, right? How are you going to take it, right? Instead of, I'm just going to load 5 shotguns and just try to hit that target. If you only have one shot, one bullet, what are you going to do? And that makes it that much more frustrating, but that much more rewarding when you get that scientific, just that home run.
I think most doctors couldn't function under that.
It's scary.
I've known a few medical doctors who could. The vast majority could not. And what's funny is the ones who could, they would invite it. They'd be like, let's do it. Take it as a challenge. They would invite that. Yeah. Most would be terrified of it and run from it. I haven't known too many who would take that challenge. But I'd say the same in chiropractic. That's why the technique that we use is not as common in the schools. It's not super most popular because most people, when they see the pressure, go, that's for somebody else.
Yeah. Give me the shotgun.
But there are some who has a certain mentality that's like, no, that's for me. I'll do it.
Yeah. Those are the ones we try to attract here. All right. So moving on. So the next one we talked about before, it's elicit the healing. So the body's innate response to heal, right? And this is where we talked about palliative care versus restorative, curative, or whatever care, right? And so we think there's a time for both, but needs to be a differentiation of both in our minds, right? Similar to the example of when I broke my elbow and I broke my wrist and I couldn't move it, I am taking that pain medication, but knowing that is not going to heal me. And the ultimate goal to get restoration is to help my body respond and get that surgery so that it heals in the right way. In fact, I would argue it's not even the plates that are in my wrist and my elbow that's not the thing that got me function. The thing that got me function was it helping my body to heal in that right way so that I could get function. No different than for us, we're trying to help the body get that restoration into proper function. We're not there holding that joint, but we want to make sure that joint has the proper range of motion so that the pain goes away and the gate theory and all that too within that joint.
Actually, a fracture is a good example because if you have a fracture and there's too big of a gap between the two, the body can't heal it. It just stays a fracture. Mm-hmm. So you have to approximate the two. But approximating them didn't heal it. It just put it in a position where it could heal.
Exactly.
And so it's the same kind of thing. We've got surfaces that are too far apart and the body's overcoming these challenges it can't overcome. And so it just doesn't get better. But by approximating it and putting it in a position, the body goes, oh, now I can. Right. And it can do what it needs to do because now the environment's right.
Right. And so I think when let's talk about some mistakes that people make. Some mistakes that people make is they think that the absence of pain, right, equals health, equals everything's better, right? Mm-hmm. And so then they start mistaking the palliative versus, right? But yet are you better? I take an Advil every day, right? For my headaches, right? Or I slap on e-stim, or even worse, you've seen people with implants, the e-stim implants, and it's like, oh, I'm better.
Or the morphine pumps. And they'll tell you they're fine.
And it's like, we just mistook palliative for restoration of your body, right? Mm-hmm. Or a better homeostatic, right? Or whatever we want to call it. And so that I think is where people get wrong. Is where pain clinics can often get wrong as well, is mistaking the absence of pain for health.
Another one I've noticed with people is that they think that the severity of pain equals the severity of the problem. So a lot of pain is a bad problem, not much pain, not a bad problem. Whereas you can have a horrible problem with not much pain, and you can have a lot of pain with something that's not a bad problem. My pain yesterday was horrible, but I was laughing it off because I knew it wasn't a big deal. It wasn't that big a deal. I was still seeing patients in spite of it because I knew what it was, but it hurt really bad.
Good man.
I've actually, one of the examples I was thinking of is I guess I'm a klutz. I dropped a desk on my toe at one point, and I broke my big toe in 3 places by crushing it. And I then proceeded to unload another desk from my truck with it broken, and then got in my truck and drove myself to the doctor. About the time I got to the doctor, I started going into shock. And so now shock became my biggest problem. So they gave me pain meds, and it kept me from going into shock, and that was good, but it didn't heal my toe, and it didn't fix the problem. It just kept me from going into shock. And so in that regard, I'm thankful that I had the meds to keep me from going into shock, but there was still some stuff that needed to be done. In fact, at some point, I eventually, once it healed up, I had to adjust my own toe because in addition to smashing it and breaking it, I had also misaligned it. And I just got all this pressure in it. But fortunately, I can reach a toe. I had to adjust my toe. And when I adjusted my toe, all of a sudden, I had more function to it. So it had all these elements all wrapped up in that one injury. And that's how most injuries are, whether it's a slip and fall and you land on your tailbone or you tumble down the stairs. Sadly, I've done all of those. Like no matter what it is, when you have the crash landing, you hope you don't do it with so much force that you break a bone. But even short of breaking a bone, you're still probably misaligning things. I've always told patients when you have a collision like that, the joints allow them to move you're allowed to move the joints as far as you can until they just can't go anymore. And that's when you break a bone, if there's still energy passing through. Right. So the fracture always happens on the far side of misalignment. So if you have a fracture, I know you have a misalignment. You have to. Right. That's the only way you can get to the fracture part, is that the joints are already all used up and there's nothing else to absorb the energy. And as that energy continues to go, it busts through a bone. So it's just like transition of forces. So anytime anybody's broken a bone at any point, you probably have a misalignment as a result of that may or may not have gotten fixed.
Right. Well, that's a perfect segue to that to principle number 4. So principle number 4 is evaluate objectively, right? And so similar to basically what you said in terms of the fracture, I think actually taking a step back, I think we talked about this pain as the alarm system, right? And that pain is not an accurate indicator, as you just said, with how severe the problem is. As we know, when people come in here, the vast majority, wouldn't you say the vast 95+% of people come in here not because of a traumatic accident that happened yesterday, right?
Yeah.
It's usually the straw that broke the camel's back.
Mm-hmm.
And then the pain starts happening, right? And so the alarm starts going off because the fire has been blazing for a while and there's been a cause or whatever, right? And something that's been going on for a while in that person's body.
Mm-hmm.
Well, if that's the case, then is that the best indicator that you're better, right? And so people chase that pain so bad. But man, when I say, this is what I tell people, if you're just here to get pain relief, an Advil is going to be way faster and way cheaper than anything that we could possibly do, because I'm out to fix the cause. You just told me there's a fire alarm. I want to be that firefighter and the construction worker that rebuilds it. I'm not here to just say there's a problem with your fire alarm, right? But I think that's where most people gauge the wrong thing in terms of better, worse. I'm healed. I'm not healed. Pain is not that.
No, pain is deceptive. But pain actually works on a threshold, and
yes,
so
that's right.
When it switches from nothing to something, your brain goes, "Oh, that must be pain." But then if it stays as something for a long time, your brain starts to ignore it because then there's too much white noise. So it starts to ignore it, and then when you go from the problem to fixing it, it registers that change as pain.
Right.
So that you actually have more pain when you're getting better, because the brain, all it knows is it was this way for a long time and now it flip-flopped. Something changed, and all it knows is to perceive that as pain. And so it flips back and forth. And so it's really just working on a threshold mechanism. And so you really can't trust that too much. It's easy to deceive. In fact, there's plenty of drugs that do that. Like, there's lots of drugs that change your pain threshold because they alter the threshold. So then if you're on these drugs for a while, you start to get very sensitive to pain. So the tiniest little bit of pain, actually opioids are a good example of that, actually. Almost any opioid. It reduces your sensitivity to pain so that it takes less pain to have you running for another opioid. Mm-hmm. And so while the first one may have been like, oh, what a relief, it got rid of this horrible pain I've been experiencing, you eventually get to the point where you're like, oh, the wind's a little strong today. I better take an opioid because it's starting to hurt my arms. You get so sensitive to it. And that's that alteration. And you don't want to mess with that alteration. You actually want a body that's pretty robust, because I always find it interesting. I have had countless patients tell me, well, I have a high pain threshold, as they're sitting in the office complaining about pain. Yeah. I've never had anyone tell me I have an incredibly low pain threshold. Like nobody's ever said that. And yet I've had patients, even the ones who said that they had a high pain threshold, that I was thinking to myself, you have an incredibly low pain threshold, because some things, there is an objective amount of pain that associates with certain problems.
Right.
And when it's out of proportion, you can go, well, you're lower than most. You're more than most. So there is an objective measure of your pain too.
Right. Even among people who are athletes versus more sedentary, that threshold is different as well, right? And so as much as we said before, that pain it's a blessing that you actually have a signal system, right? It's not the only signal system, and it's not reliable for health versus not health, right? In terms of the joint. So when it goes off, you better pay attention to it. So I think people intuitively know this, because I draw this example out of people. The killers of the top killers in terms of America, right? You got cancer, you got heart disease, right? And well, can you feel those, right? And so is it an accurate indicator if you can feel like the cancer? By that time, it's pretty far gone, right? Mm-hmm. Pretty far in. Same with heart disease. If you can feel problems in your heart, there's been a problem going on for a while. How come it's not the same, right? When people come in, short of the trauma that happened yesterday, isn't it the same, right? When it's finally reached that threshold.
Yeah.
Yeah.
Yeah. It's funny how we see it that way, because I've known, sadly, a number of people who were young, who are healthy, would have told you they felt great, and the next day they were dead. One from cerebral stroke,
Mm-hmm.
heart attacks, a number of people like that. And it's funny because they think they're healthy because they don't have pain. And yet you're healthy if you're doing the things that create health. That really health is nothing more than proper functioning of your body.
Mm-hmm.
And then disease is dysfunctional functioning of your body. And death is no functioning of your body.
Right.
So you have this continuum where health is not actually part of this continuum. Health is at the top. And anything less than that is this process of going from functioning to not functioning.
Right.
And in the middle is dysfunctioning. And so there's so many different levels of dysfunctioning. There's light level of dysfunctioning where you've got a simple little problem, no big deal, we fix it. Then there's people where it's like you're heavily dysfunctional and you've got layers of dysfunction layered on top of layers. And so there's just this whole continuum. And so that's why you can't just put people in a box. They could be anywhere on that huge continuum.
Right. Dysfunction, people are often surprised when they come to our office when we ask about how's your digestion, right? How's your blood pressure, right? Asthma, right? Why are you asking me this? You're a chiropractor, right?
Mm-hmm.
Aren't you a pain doctor? Well, we just said no, right?
No.
That's one thing. That's one
Pain's a
signal.
great clue.
It's a
but
clue.
It's not the only clue.
Right. So when we ask these things, we're still trying to get a piece together. What's the dysfunction? And continuously piecing together that dysfunction of that's another signal, right? That's another signal. What are these clues? What are all these fire alarms pointing me to? And so having an objective way to measure progress, right, with x-rays, right? And then I think Gonstead saying people don't re-x-ray enough. But also the nervoscope is another objective tool for us. Honestly, even people's blood pressure and things like that, right? Getting better or other types of objective measurements. Obviously, Dr. Gonstead had his own blood lab in his clinic. So having objective measurements, not just relying on absence of pain, is so crucial, so crucial. So
Well, I'm thinking about all the symptoms we follow that have nothing to do with pain. Things like if somebody's got a watery eye, if somebody's got congestion, there's a lot of other symptoms we chase after that sometimes mean more to us than the pain because pain is such a liar. Not that it means to be, but pain is because there's so many different nerves and so many different trails. It's easy for pain to be deceptive.
right.
For us, for the person who has it, but even for us trying to chase it back. We try to chase it back when we can, but I always think if I can take this pain and chase it back and then find other symptoms that confer, then I'm onto something. But I don't want to believe just the pain alone, but you look for these other symptoms, even changes in the skin.
Yes.
So many different things that have nothing to do with pain, but they all are giving us information as to how the nerve is functioning. And that's the part we actually care about.
And it's funny because early on in practice, I can very clearly remember, and this is something that we train our doctors in, is try to talk. I'm like quiet in the room, just thinking and thinking and thinking. And it's awkward, but I don't feel the awkwardness. Maybe it's the introvert in me. And I'm thinking of their case history, their x-rays. I'm just thinking in the room like, oh, hey, how's it going? So there's so many things that go in our head. The skin changes, looking at it, and like where it looks like it's pitting just along here, right? Early on in practice, you're just focused on that. If you're focused on the right things, sometimes it's at the expense of awkwardness for the patient.
That's one of the reasons why we gown, is because it does make the scope a lot easier. But I often think of how often I'm picking up on things that I don't even know I'm picking up on, but as my hand's touching it, my eyes are seeing it, my brain is making a connection and realizing there's something here. So there's that happening. I had a patient one time where, it was a weird story, but I was scoping him and I noticed he had this mole. And then one time when I was scoping him, the mole had changed and it looked different and it had this irregular border and all this stuff. And I said, you need to get that checked. So the next time he comes in, he goes, my doctor said it's nothing. And I said, really? And he said, yeah. And I said, well, did they take your shirt off and look at it? He goes, no. Did they touch it? No, they didn't look at it anyway. He said it was a VA doctor, and we told him that his chiropractor said he had a mole that had changed. He said, no, it's nothing. That was his response. And I said, a different doctor. So he ended up going to UCLA and going to a cancer doctor. They put him in a gown. He said the doctor walked in the room and from across the room goes, that's a blah, 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 whatever. It's coming off today. And they had it removed. And they said it actually had that point where it could have gone malignant and could have caused us trouble. And so then, I don't know, a week later, his mom came in to see me, and his mom said, I mainly came in because I want to say thank you for saving my son, for actually doing all this. And I thought, how sad that it took a chiropractor and an actual cancer doctor to look at the patient and feel the patient, while somebody in the middleman would have just shut the whole thing down and said, no, it's nothing, but didn't even bother to do the details. And I think that's too much what people run into, is the person who has, I guess, clout or some kind of something, but they just didn't do the job because they made an assumption. And I've learned with what we do, assumptions kill. I never make an assumption. I'd be like, it's probably nothing, but let's still check anyway, just to see. And that's why that lesson taught me that.
How many things have we caught in X-ray that,
Lots.
thank you. And so again, getting that diagnosis, super important. And the last principle is develop a plan, right? And so people are always surprised again that we're asking about either autonomic symptoms, right? And we're asking about sympathetic balance. We're asking these type of questions. Yeah, I get that people come in with pain, so I'm probably going to focus on it. They're like, oh, that's random that you're asking that. But really, it's about developing a plan to address the tertiary, secondary. What order am I going to start doing things in, right? Because if you don't have a plan, it starts becoming haphazard, right? And it's like, I don't even know when I'm going to see you next. And then you start addressing the short-term things, right? Just to get a happy patient.
Mm-hmm.
But really, do you have a plan to unravel this? Because if it is the straw that broke the camel's back, and there's been something going on in a fire that's been going on for a while, then are we just what part are we going to work on? There's so many things that have been burned down. What are we going to work on, right?
Mm-hmm.
And so for patients, if we're talking about real health, there needs to be some sort of plan for unraveling it. It may involve a surgeon. It may involve, there's so many things that it can involve. But if you don't have a plan of how do you going to unravel it, then how discouraging is that?
I think a real simple example of doing these in order is how it happened countless times. A patient comes in and says, oh, I've got a bad rib. I have to get this rib adjusted. It feels good when it's adjusted, but it never lasts. In that situation, it's almost always because you actually need to adjust the vertebra before you adjust the rib. And the vertebra almost always has a problem on the opposite side of the rib.
Mm-hmm.
So then what I do, I don't assume. I go through the motions, scope it, palpate it, do the whole thing. It'll be there. I know it's going to be there, and it always is. Adjust that vertebra the way it needs to be adjusted, then set the rib in. And then they always come back and go, not only is it gone, that's the first time it's ever stayed gone. It needed a good foundation. It's like trying to rebuild the walls of a structure, but the foundation's cracked. You're wasting your time. You have to build the foundation first. And I think that's one of the big things about our concept is looking at what is the foundation of this? What's producing the pain, but what's the foundation of the whole concept? And if that pain producer is one of the walls and not the foundation, then we've got to go back and fix the foundation first. Then we can rebuild the walls. Then we can actually fix the problem and keep it gone. Right. And fix it that way. So it's really always looking, in fact, Dr. Gonstead's principle was called the foundation principle. It's all about finding the foundation and building the foundation so you have stability.
Right. Yeah. And I think one of the most difficult cases for most chiropractors is scoliosis, right?
Mm-hmm.
Well, one, because they don't take a full spine x-ray, so they don't even know if you're only looking at a certain portion. You have no idea how everything interacts with each other. But if you don't have a plan with scoliosis, there's no way you're going to address everything in one visit, right? But what's that plan? Now is the case for Kat. Just come in. What's the plan? What's the plan? The plan is I'm going to stick electric stim on you today. That was for 2 years. You're just getting electric stim, and then it's like, this is not working. What's the next step? Oh, the next step is electric stim, right? Or the next step is just adjust you again. That's not a plan, right? And so scoliosis is one of those profound things where it's three-dimensional. Obviously, we try to read on it, but for a long time, her odontoid was far off of her S2 line. Well, how far are we really going to get? You may have symptoms elsewhere that, if it's really bad, we probably have to adjust it. But what's the next step, right? And that's one of the things that appealed to me in Gonstead is there's a plan, right? We're going to work on this, but that's not going to last until we work on this, the foundation.
Every adjustment you give needs to have an expected result. So if you adjust something, it's, I'm doing this because I expect it to have this effect and affect the symptom this way by fixing this. There's a story. I've always said it's the story. You got to have a story. If there's no story, I'm going to push on this one because it looks really misaligned. That's not a story.
That's good.
So like scoliosis, where are you going to push? The one that looks the most misaligned. That's actually probably the last one you should push on. So you don't have a story. You need a story as to why neurologically or biomechanically you think it's going to make a change. And then when you have a story, then you can, down the road, as you're learning more information, you can amend the story, you can add to the story, you can do stuff like that, but you have to have a story. Otherwise, you're just popping and praying, as they say.
Right.
Like, I hope something good happens. I don't know why I would expect it to. Just do it anyway.
Right.
That doesn't work.
So even with relating to a plan in that story. Maybe it's that story for that person is something that they continuously do, right? Some sort of activity. Well, what's your plan to maybe alter that activity? What's your plan to maybe modify your work, right? Because you might have a spondy, right? And so what's that plan? If there's no plan, it just becomes a revolving circle, right? And one thing we never want to do is just, and it gets boring for us too, right? Addressing the same problem over and over and for that same person because there was no plan to stop that, right? What's your plan to do that? Maybe it's some rehab, right? You need to stop doing that. Learn how to sit or learn how to walk, right? I don't know what it is, but there has to be some sort of plan that addresses that story of why they came in the first place. Again, barring a traumatic incident, then maybe just drive better. But
I would say a lot of times, sometimes half the patient visit is actually just re-educate them on how to do things they need to do that they might be doing correctly. A common one has to do with sleeping habits. So I need to know, based on the problem they have, do they sleep on their side or on their stomach, on their back? How do they like to sleep? How do they feel in the morning when they wake up? What's bothering them? How can we change the bed, the shape of the bed? How can we make some amendments that'll actually make it so they can get good sleep and wake up not in pain? And more importantly, not be messing it up for 8 hours every night while we're trying to fix it. And that's a simple one. But then it's your work situation. Are you sitting? Are you standing? Are you walking? How do we change that? Your car situation. What's your car like? How do we change that? And you make all these different changes because any one of those could be setting you back as far as you're going forward. And if you don't get that done, then it does become the habit of I fix it, you go mess it up. You come back tomorrow and I fix it and you go mess it up. And that's as frustrating for me as it is for them. So let's fix the situation, whatever that may be, and make it so that when do you notice that it gets worse? Well, whenever I sit in that chair, first, don't sit in that chair. Let's start with that, because if not sitting in that chair solves the problem, then we know that chair's the problem. So then we can make changes. If not sitting in that chair doesn't change the problem, well, then it's probably not that chair. There's something else happening. So it's playing Sherlock Holmes and putting the clues together and figuring out what's really happening here. But as you make those changes, that is another huge part of the equation, is changing how we live our lives, the habits that we have, and how we do the things we do.
Right. It's the 3 T's that
trauma, toxin, and thought is never changed.
Exactly. So if we're not having a plan to address those things and continuously re-educating, right? Honestly, some of the best physical therapists, I've studied a lot of physical therapy. Some of them are very religious about, I need to continuously retrain their motor patterns as well, right? Because we don't live perfect lives in perfect bubbles, right? And so sometimes we mess up. And so how do we retrain it before it becomes a bigger and bigger problem, right? No different than your pelvis never being addressed. How does your headache not become a bigger and bigger and bigger problem? How do we address these things? So, let's be proactive a bit.
I also use the example of golfers, because golfers are very programmed on exactly how they want to move. And then I ask them, well, what happens if you're in a bunker and it's an elevated bunker and you got your left foot higher than your right? No, I messed up my shot. Well, of course it does, because you're used to hitting flat. So you put a little elevation there. So it's the same thing with any of us. Whatever we do regularly, we're used to doing it in a certain environment. All it takes is some little thing changing how we balance or how we shift or how the position we're in. And now our brain's like, I don't know how to do it. It just gives up. So it's like all of that kind of stuff. So you have to retrain motor patterns, but even then they're only good for so long, assuming a given environment.
You still need a coach.
And you still need some help.
Once I get it, I'm good forever too. You still need a coach. You're starting to mess up again, and that's going to mess up your shoulder, right? And so, honestly, I think people again kind of mess up that thinking, and then get themselves into trouble. I'll just come back when I feel pain again and go into that cycle again. So cool. Well, so again, just to wrap things up for this episode, what we really wanted to do is just make sure that we talked about our experiences in practice, where we feel like, even with my wife going through that thing, we totally get it. Where is the difference between palliative versus restorative? Where are we talking about MRI is not being a good standard? Hopefully this helps someone understand where there might be a better methodology, where they might start, right? And we're not saying it's always starting with chiropractic, but get a better diagnosis, right? Understand. Don't just go for the tool before you get a really good diagnosis. And is it in the right order, right? Well, one thing I always tell people is keep asking why. Just keep asking why. Why do I have that herniation? Do most people know? Why do I have that herniation?
No.
But we're going to answer that. So why do I have that herniation? So why do I have the pain? Is there a disc herniation? Why do I have that disc herniation? oh, I have a unlevel foundation in my pelvis. Well, why? Right? And if you can keep understanding that, then it starts helping you understand what's most important, right?
Yeah.
And then so again, right tool, right order, making sure that we're talking about restorative versus palliative in terms of assisting the body to heal, and then also evaluating objectively, not just pain, and then make sure you have a good plan to unravel things in the future.
Yeah.
So cool. Well, that just about wraps up this episode, but look forward to the next one.